Welcome, everyone. Today's webinar is around self-management support and population management. I'm Mike Hindmarsh. I'm the operations lead at CCMI, and I'll be stepping you through this webinar. And I'll hand it back to Troy to begin the recording and do some housekeeping.
Okay, if you could just click through one slide.
Oh, sure. Sorry about that. Now, wouldn't you know it, my slide advancer isn't working.
Technical difficulties, always a problem.
Hold on one second. Okay, let's see. I'm going to stop showing my screen for a second, Troy, and then if you can hand it back to me, that would be great. Oh, I can do it here. Okay. See if that's all. Yes, that seemed to solve the issue.
Perfect.
Okay.
Apologies, everyone, for that little technical difficulty. But if you're joining the webinar and you've been on these webinars before, this will be a review for probably the 20th time, it'll feel like. But anyway, this is what you're going to see on your screen. You should see on the left the presentation window, on the right the GoToWebinar control panel. The control panel has a number of features that we're going to walk through. Really, we're only going to use two today. So, Mike, if you could advance to slide 1. Here we go. So the control panel has the minimize option, which is the orange arrow at the top. You can expand and collapse your control panel to move it out of the way of the presentation so you can have the full view of the presentation. Or if you need to use a control panel, go ahead and pop that out and use the control panel. The one option that we have in the control panel today is the question box. And like all the other webinars in the past, if you have any technical difficulties, drop your questions into the question box. And if you have any questions pertaining to the webinar, put them into the box here as well. And I'm going to look at all the questions and forward them to Mike. The ones that are pertaining to the webinar, they all go to Mike, and Mike will have some time at the end of the webinar to field those questions. We really do appreciate any question that you have. Some participation is nice, some fresh ideas, some fresh questions. So we do definitely encourage you to use the question box. And I think that's it from my side, Mike.
Great, thanks so much, Troy. For those of you that have attended previous webinars, these strategic foci will look familiar. For those of you that are new to the webinar, the British Columbia Ministry of Health has prioritized across sectors the key things that they want to be working on over the next 2 years, 2015 through 2017. Those 5 areas are to improve access to primary care through a primary care home model, and you'll be hearing more about that in the future. Reduce demand on hospitals by improving care for seniors. Reduce demand on hospitals by improving care for those with mental illness and substance abuse issues. Improving access to surgical services and procedures. And improving delivery of rural health services. So keep these in mind as we go through the presentation, because these are the areas that we want to think about in terms of as we do quality improvement and as we do self-management support, how will it impact some of these strategic priorities? The other important thing to think about is British Columbia has adopted what we call the triple aim. It is a very straightforward concept of making sure that we have a good experience of care, that we deliver population health and have healthy people, and that we create a model of care that is affordable and sustainable. So one of the things that's going to be very important today is this notion of population health, because we are going to be talking about self-management support and how do you deliver it to a population of patients. So again, keep the triple aim in mind in terms of the types of improvements I'm going to be talking about today and how it would impact the various parts of the triple aim. Now at CCMI, we have developed what we call the stepped care self-management support model, and it gives you the key elements of what you want to be doing in terms of self-management support interventions depending on your patient population. So when we look at the bottom of the model, here we're talking about your community, and at a minimum we want to make sure that we recognize the diversity that's in the community. We be culturally competent around different diversity in the population. We want to make sure that there's an equal level of health literacy for all people. It's a huge issue, as you all know. We actually just finished an interesting study in Ontario here that showed that 50% of people that were literate were not able to understand healthcare instructions. So health literacy is extremely important. And we want to make sure that we engage the community and get people engaged in their day-to-day care for themselves. For some people up on the next level, the green level that you see there, it will be very useful to do goal setting and action planning with them. And you've heard about brief action planning in previous seminars. We want to help them problem solve their particular issues that they feel are important to them, and check on how they're doing. Check on the plan, follow up and see were they able to follow through and complete their action plans and reach their goal. For some people, action planning may not be enough, and they may be ambivalent. They need more help to get motivated to take care of their health, and that's where we talk about interventions such as motivational interviewing and additional support mechanisms. And then finally at the top, we have people that are very complex, either complex clinically and or behaviorally, and have very low confidence and difficulty in taking care of themselves, and they may need specialist care and other types of specialist interventions to help them move forward. Now, it's important to remember these, certainly the top three, because these top three segments are going to come up as we talk about population management later in the presentation. So the objectives for today are to describe population management, describe population segmentation, and discuss the utility of population segmentation when delivering self-management support. And then we'll review the self-management support segmentation tools application in everyday care. I'm going to be showing you a tool that you can use during care for your patients. So let's talk about population management first. There are all sorts of definitions of population management. You've probably heard the term population management, population-based care. There's numerous terms and numerous definitions. I choose this one because I find it very useful. And it encompasses most of what I think about when I think of population-based care. So a population health perspective encompasses the ability to assess the health needs of a specific population, implement and evaluate interventions to improve the health of that population, and provide care for the individual patients in the context of their culture, health status, and health needs of the populations of which that patient is a member. That last part is very important. Many individuals do what we tend to do in healthcare is every patient is deemed as completely different, and that is good from a patient-centered standpoint. You certainly want to work with them, recognizing these individuals, but quite often their care needs are very similar to many other patients that are either in the same kind of cultural segmentation, clinical segmentation. And so what it helps you do when you think about population management is plan the services that you're going to be delivering to people and have an idea of how many patients you need to deliver a particular type of service for. We'll talk a bit about that when we get to thinking about segmentation. So on that note, when we talk about population segmentation, this is just what it sounds like. It's talking about grouping patients into groups that are meaningful for you when managing that population of patients. So the definition here, segmentation, is grouping the local population by what kind of care they need and as well as how often they may need it. And so again, it's not limited just necessarily to the care that they're receiving. You might want to segment populations in different ways. So here are some examples. You might segment populations by a chronic condition that the patient is living with. This is probably the most common segmentation that you've seen. You've heard about registries of patients with diabetes or patients with congestive heart failure or depression. So that's a very common way of segmenting patients and looking at the care that the patient needs. We could segment by preventive care. So people over 50 years old, they're appropriate for colorectal cancer screening or other types of preventive care in the age brackets or cultural and racial status that may be appropriate for them to receive some type of preventive care. You could also do it by cultural care, whether you're sorting the population perhaps by indigenous patients, refugee patients, in which case you want to be looking at is trauma-informed care and what level of psychological intervention you want to do with them. Immigrants that are new to the country and may not speak English. So again, cultural care segmentation is another way to go about it. All of these can actually be blended together. So you could create a registry of a population of patients living with diabetes, and you also subsegment them into their hemoglobin A1C levels. So those people that are less than 7 and in good control, those that are between 7 and 9 in fair to poor control, and those greater than 9 that are in very poor control. So again, having one segment at the highest level means that you can subsegment down below. And that's actually a key concept for us to remember as we go through the rest of this presentation, because I'm going to talk to you about how do we take a population of patients that need self-management support and subsegment them based on a couple of criteria. So when we talk about self-management support, I want to review the definition with you. Self-management support is the systematic provision of education and supportive interventions by healthcare staff to increase patient skills and confidence in managing their health problems. I've underlined confidence here because this is going to be a key way to think about segmentation when we think about providing self-management support to patients. Confidence is a very easy thing to measure with patients. There's a variety of tools for doing it, a variety of ways of doing it. Here's a very simple tool that's easy to use in practice. You can simply ask the patient, how confident are you that you can control any symptoms or health problems you have so that they don't interfere with the things that you want to do? Now, the question is an important one, and especially that last phrase, the things you want to do. Because what we often hear from patients when they talk about chronic illness is they don't talk about wanting to control their A1Cs or reduce their cholesterol or improve their triglycerides. They say, I want to be able to live with this chronic condition so that I can do the things that I want to do and the things that I used to do. So it's a very important question to ask, how confident are you that you can manage your health so that you can continue to do the things you want to do? And you can circle, simply the patient can look at the scale. There are other analog types of scales that can be used, and they circle the number. If they circle anything less than 7, what you've got is you've got someone with some confidence issues and that they're not quite sure of how to take care of their health so that they can continue to do what they want to do. If they circle 7 or greater, you've got people that are pretty confident that they can manage their care. So when we think about population management and segmentation, this is a very simple tool that was developed by CCMI. We're still in the process of validating it, but it worked in the trials that we've used it in. It's worked very well and helped clinicians think about how to help patients with self-management support. So the two factors here are patient control, and that could probably be clinical control of their condition, and confidence. So across the top, we have good control and poor control. We have high self-confidence and low self-confidence on the y-axis. And so what goes inside those boxes there? If you look at this particular screen, you'll see that what you're doing is that you can support the segments differently. So we don't have to do one single self-management support intervention with everyone, which may not be useful for some patients, may not be enough for other patients, and may not be the best use of all of the limited time that you have. So if you look at these segments, you'll see that patients who are in good clinical control with high self-confidence probably just need usual care. Check in with them occasionally, make sure things are going okay. The check-in is important because, as you know, control can slip, confidence can slip. So periodic checking in with them would be useful during usual care. So that check-in might be checking on their confidence and of course, looking at their clinical control. The two yellow areas are places where you can use action planning, and specifically brief action planning is an excellent tool for doing that. So some patients may have good control, but they're not really confident that they can continue to take care of themselves, especially if something goes wrong, if they get some kind of illness that might affect their clinical control for their chronic condition. So you might want to do some action planning with them and setting goals to make sure that they understand what to do if an illness pops up and how it might affect their chronic condition, their medications, that sort of thing. The goal here, certainly for the patient, is learning how to manage while they're feeling sick, but also the goal for you is to build their confidence so that they go up into the green category of good control and high self-confidence. For folks that are in poor control but have high self-confidence, again, brief action planning is a very useful tool to use. We can take that confidence and work with them to identify the issues that they are struggling with, whether it's a knowledge gap around how to do particular self-monitoring tools or self-monitoring activities, or knowledge around diet and exercise, but they've got good confidence, and which is an excellent start for them to start thinking about how can they improve their control, whether it's through medications, diet, changes in the treatment plan. And then in the red category, we have folks that are in poor control and low self-confidence, and these folks tend to be very complex. In this situation, you want to make sure that you really don't give advice to them. You don't sort of assume that they can take care of themselves and tell them what to do. You really want to explore with these patients through techniques like motivational interviewing or ask, tell, ask, or other interventions that are more in depth, that are built towards helping the patient deal with ambivalence and deal with that low confidence around taking care of themselves. So you can see how using a simple tool such as the confidence scale that I showed earlier and your measure of good clinical control and allows you to segment the population. I think the important takeaway from this is it tells you that not every single patient in your group of patients needs to do brief action planning or needs a self-management support intervention of some sort. There will be a good chunk of patients that simply need usual care and checking in to make sure that their control stays, their disease state stays in good control, and they maintain their high self-confidence. So let's run a few examples of this through the segmentation tool. We'll start with John. John's disease is well controlled. He's sure he can take care of himself. He comes to all of his appointments, monitors his condition, and adjusts medication as needed. So I think this one's pretty straightforward. If we go back up to or if we go down and look at the segmentation tool, you'll see that John fits into usual care. He's doing a great job of taking care of himself. You just need to see him periodically based on whatever the evidence guidelines are for bringing people back in good control and make sure everything's all right. If we look at Tanya, her disease is well controlled right now, but she's unsure of what to do. She's had a hard time getting started with some things. So here we have a situation with Tanya where she's in good control, but she really has low self-confidence about what to do. And again, it may be a knowledge gap. It may be what to do when I have an exacerbation, what to do if I get the flu, those sorts of things. And so brief action planning is very useful for her, as well as probably some education, if she's interested, around what it is she's got low confidence in. Simon, disease is not in control, says he knows what to do and is sure he can do it. So this is a situation where we have poor control, but Simon knows exactly what to do. So we can take advantage of that high self-confidence and find out from him what are the issues that keep him from managing his health so that he is in good control, and then address those issues with brief action planning. And then finally, we have Nellie. Her disease is poorly controlled. She knows what to do, but there's many responsibilities in her personal life, and she's unsure she can manage it all. Others in her life come first, and she's overwhelmed. And there's lots of patients like this. And so again, based on the segmentation tool, she's going to fall into that category: poor control, low self-confidence. You saw from the example, she knows what to do, so she doesn't need a knowledge intervention. She really just needs to know how she can fit in taking care of herself amidst all of the other priorities she has around others in her life, and how to help her with that overwhelmed feeling. So motivational interviewing and those sorts of techniques help pull her back into looking at her own self-confidence and what she can possibly get done. Remember, the key to self-management support is not to have a single intervention that gets someone right back on track. They need to have small successes over a period of time to build their confidence. So Nellie is going to need a lot of work in that direction, setting achievable goals that are specific, measurable, actionable, relevant, and timed that she can accomplish and build her own confidence. So you can see quickly how you can start sorting patients, and what we have seen when we've tested this, we actually had the luxury of testing it in Kazakhstan and other places, is that the clinician begins to understand how to use, once they're comfortable with this tool, they begin to understand how to sort the patients very quickly in terms of what intervention they're going to deliver. And then, of course, they're checking with the patient to make sure that their sorting at this point is correct. But they get a good feel for it. They build the confidence question into the clinical visit. So perhaps it's whoever rooms the patient while they're taking vitals also asks a confidence question. It can be done a variety of different ways. So that leads us to, okay, now you've got a segmentation tool. What are you going to do with it? And this very busy slide is an example of an algorithm that we've created at CCMI that helps you sort of step through how you would deal with those segments and what kind of interventions you would deliver to patients. So if we start up at the top where it says SMS needs assessment at every visit through conversation assessment tools, you assess the patient, and the question, the diamonds here mean a question, is the patient in good clinical control and has high self-confidence to manage their age-specific prevention and chronic illness needs? If the answer is yes to that, then encourage the patient to maintain contact with you and ask if there's any questions or information that they need, and continue usual care. That's remember the green segment in the population segmentation tool. These colors correspond to that. You might even want to engage and have a peer mentor work with them, someone else that is in good control and high self-confidence that they can bounce ideas off between visits. If, however, the answer is no, they're not in good clinical control and high self-confidence, perhaps there's a knowledge gap you might want, or perhaps there's misinformation. That would be the next thing you would want to know. And if the answer is yes, there's some misinformation about what the patient knows about their condition, you can use interventions such as Ask, Tell, Ask, which you've heard about in previous seminars. And you can use patient-centered education programs to help close that knowledge gap. If the answer is no, that the knowledge gap isn't the issue, you want to check in with the patient and ask the question, do they want to make change? And do they need help? And if they say yes, you can use brief action planning. You can tailor the follow-up to support whatever needs they have. You can repeat brief action planning as needed and assist them with problem solving. And then the question would be, are they ready to self-manage? And if the answer is yes, then you would come right back up the arrows again to the green box at the top and encourage follow-through with the patient-directed plan and encourage contact with the patient and fill any information needs that they have. If at this point, after brief action planning, they're still not ready to self-manage, the diamond down at the bottom there, and the answer is no, then these are the folks that are going to need more specialized interventions. Motivational interviewing, home visits as needed, are quite often powerful. Stepped up care to meet their needs. So maybe they need to go to behavioral health and receive some behavioral health interventions. Involving the circle of family, their family and caregivers, maybe more community resources if they exist in your community. And sometimes group visits are a very good way to help these folks that are struggling with their control and confidence by sitting in a group and seeing that other people share the same problems they have, and others have tried different things that may be useful for the patient with low confidence. It can be a very powerful experience that helps build their self-efficacy. So I didn't go through all the possible angles. I covered just about all of them, but it's a very nice algorithm I would encourage you to print it and laminate it like you would a guideline and make it accessible during the clinical visit, so that as you're starting to work through with the patient what their self-management support needs are and what their confidence levels are and what their clinical needs are, this algorithm would be very helpful to step you through and decide what should I deliver and to which patients. I just want to go back to the segmentation grid for 1 second. It would be very important that as you start asking patients that confidence question, that you maintain some kind of registry around this particular population segment. So you could call it a self-management support registry, and it could be disease specific, it could be just chronic illness in general. Again, you would have to make those decisions. But what you should keep track of are the numbers of patients, of the total population, of the number of patients that fall into each of these categories, so that you can start saying that on a monthly basis, we know that of the 2,000 patients that we see, 2,000 patients that belong to our population, maybe 1,000 will not need any intervention except usual care. Maybe 500 will need either brief action planning for confidence or brief action planning for poor control, and maybe 500 are complex. I would hope that 500 are not that complex, so that's probably not a great number. But what it does is allow you to start planning the resources in the practice so that you can say, we've got a large number of complex patients. We've got to be ready at the visit to do self-management support, perhaps referral to behavioral health, and it helps the practice get much more organized and less reactive to what's just coming in the front door. So I encourage you to think about how to fill this grid out with numbers, to start doing population planning for your population of patients, as well as using the algorithm for individual patients to see exactly what they can use in terms of self-management support intervention. Now, in my last talk around quality improvement and the fundamentals, or self-management support and the quality improvement fundamentals, I talked about the model for improvement. And part of that model was the Plan, Do, Study, Act cycle, which is a rapid cycle technology for testing ideas very quickly, gaining knowledge, and then moving on to either continue testing the idea or maybe you modify the idea and test that. But the key thing here is to test ideas very quickly and learn from them so that by the time you get to implementation of whatever intervention it is you're trying to do, you know all the things that could possibly go wrong and you've designed it so that nothing will go wrong during implementation. I'm just raising this now because I think it's important for you to start thinking about how could you PDSA, how could you test this segmentation grid, how could you test this algorithm and see if it's something that you can integrate into your clinical practice. So if we look down here, when we do PDSAs, we usually have to do multiple PDSAs. It's not that often that you do one PDSA and the idea is so good you're ready for implementation. Usually you need to test a bunch of different things. Now remember, as I step you through this, we're talking about testing small and testing quickly. This is not about research. We're not looking for statistical significant change. It's not about accountability or evaluation. We're really just looking at knowledge for quality improvement. And that means good enough data that you can observe and tell yourself, this idea when we tested it worked, it didn't work, and if it didn't work, this is what we want to do next. So if our overall objective is population segmentation for delivering self-management support, we might have a series of PDSAs that start with our hypothesis. Can patients with diabetes be segmented for targeted self-management support interventions? That's the piece at the bottom left-hand corner there. In the first PDSA cycle, you might have the nurse ask confidence question with 2 patients. And what the nurse finds is that the patients can answer the questions very easily. She gets a confidence rating from them, and it's easy to record that in the medical record. Now, electronic health record conversation aside, you would want to be able to track this information somewhere, but you will have to figure out how to build that into your electronic health record, and we do have some recommendations for that. Cycle 2, the same nurse tries using the algorithm that we showed you. It's pretty complex, tried it with 10 patients. She found on the first couple she kind of got lost. She wasn't quite sure what the answer was or how to clarify with patients. So she huddled with her team and said, I kind of got lost here. Any recommendations? And the team gave her some recommendations. And She may have gone off to the side and tested that a few more times until she was comfortable with the algorithm. Now that she's comfortable with the algorithm, the confidence question, we can look at cycle 3 where the RN uses brief action planning with 10 patients. Maybe they've gone to a brief action planning training that we are offering through the Ministry of Health work, and gets comfortable practicing that and finds out how it works during practice. Does it fit into the office flow? Does it fit into the clinical flow? Do they do it before or after the MD visit? And gets all those bugs ironed out. And so by the time you get up to cycle 4, you're targeting self-management support by segment. So someone takes the confidence rating of the patient, it's a 6, but they're a patient coming in for a diabetes visit, but their control is good, they're at 6.9 hemoglobin A1C, blood pressure is good. Then you know, the nurse knows when he or she comes into the room that what you're probably looking at is doing some brief action planning to help boost that confidence. So once you do those PDSAs and you're comfortable with all those aspects of the self-management support intervention, you're now ready to implement both the algorithm, the self-management support algorithm, and the segmentation grid as a tool for managing your populations. Now, I've made that sound very easy going through this slide, but you will find that each one of these cycles, even though there may be some sub-cycles underneath them, if you keep the numbers small and you record the knowledge, that is, you do the study part, when you do it, you write down your observations and study those observations, you'll know how to act very quickly if you need to test it again. So I encourage you to blend the presentations that you've been hearing over the last few weeks, and in this case, really look at the model for improvement again and PDSA cycles as a mechanism for testing the segmentation grid as well as the self-management support algorithm. So to summarize, we talked about population management. It is absolutely critical to healthcare. The one thing that, despite a variety of different definitions, there is agreement across the healthcare community that population management is absolutely critical to the triple aim of delivering population health as well as impacting the per capita cost of patient health. We talked about segmentation and what does it mean to segment patients and what are the useful segmentations when we think around self-management support, such as segmenting by confidence and good clinical control. We talked about its application to self-management support, the grid, and where it fits in there. And I showed you the self-management support algorithm as a way of going through practice on a daily basis and working not only with the grid, but working with the individual patient to see exactly what their self-management support needs are. And then we finished with talking about PDSA and some of these ideas and using the PDSA technology as a rapid cycle way to gain knowledge into using these particular tools. So it's a short presentation today. The nice part about population segmentation is the concepts are fairly clear and fairly straightforward. So I've wrapped up this presentation. I'd like to open it up to see if there's any questions. And Troy, should they type in questions to you, or what's the best way for them to do it?
Yeah, go ahead and drop your questions into the chat box, and I'll forward them on to you, Mike, or just voice them. None yet, but it takes a little bit of time for people to find the chat box sometimes.
Yeah. While people are thinking of questions, I know one that I get frequently from providers is, how do we get others on the team to buy into this idea? And I think the best approach is to, first of all, try out the tools yourself and see if they make a difference for you in terms of your clinical practice. And then just jot down the points about what's in it for you. Quite often what I hear people say is that when they use the self-management support algorithm and they've identified the patient's needs, they find that the visit goes a lot faster. They find that the patient feels listened to and heard because it's very patient-centered in terms of the problems that are to be worked on and the assessment of their confidence level. So it builds a continuing healing relationship. And then it also helps solve a lot of those stubborn issues where you hear a provider saying, my patient is non-compliant. I know we shouldn't use that word, but that's sort of what's going through the head. And it helps uncover what are the compliance issues. It usually isn't patients being stubborn. It's usually patients not knowing what to do, and often combined with low confidence to do that. So what we're really trying to do here is build patient confidence, and these tools do that very quickly. So that's one way to encourage your team to try the tools themselves and see if they make a difference. Any questions in the chat box, Troy?
Yeah, we have one. I'll read it to you. Are there some objective questions or criteria to help segment people so that there's consistency between different providers doing this with a population?
It's a good question. So, well, first of all, you can standardize the confidence question that you use. So the one I showed you, make sure that's the question you ask each time, so that you get consistency in terms of how patients rate their confidence, and make sure that on repeat visits, say you use the same confidence question. For clinical control, it really depends what the condition is, and you may want to use objective criteria such as hemoglobin A1C or blood pressure levels or cholesterol levels, so that if a patient is in control or out of control, you can simply look at the values of their these particular tests and sort them that way. If you want to use more subjective criteria, like, I think the patient is generally doing well, and their blood work looks okay, but I think that they could go off the rails at any moment, then you need to sort of make sure that you note that as you're working with the patient. So I would just, and notes be the kind of things that would probably show up in the notes in the chart. Patient currently in good control, low confidence, and suspect that the patient could become poor control, therefore we'll do a BAP intervention. But typically for chronic conditions, there are fairly straightforward objective criteria, tests, or procedures that you can use to segment the population. Any other questions?
I don't see any more right now.
Okay. If you think of questions after the webinar, you have my email there. Please feel free to email me questions. If I don't know the answer, I'll find out the answer for you. But again, I encourage you to try using these tools and just see what kind of difference they make. You don't have to do it all at once. So just as I showed in the PDSA example, just try doing the confidence questions a few times and see how that helps you. Then maybe try using the algorithm and see how that works. If you aren't trained in BAP, talk to us, because we've trained a lot of trainers across the province who can help you learn BAP, or we can help you if that turns out to be the case. But just try testing these things, see how they feel. Let the rest of you, if you're working in a primary care setting or a specialty care setting, let the rest of the team know that you're just trying these things, and you'll get back to them about what you found out. If you're in a health authority where you're thinking about how can I take this to providers in the field, again, I would encourage you just to get used to the tools, and then you can go out and talk to them about how they may feel about testing these in their particular setting and what difference it makes for them in terms of delivering patient care. So with that, I'll wrap up the webinar. I thank you very much for listening in. This webinar will be posted on our website for others that may not have made it today, or others that you talk to and would like to view it, so it will be available to them. Troy, any housekeeping things that we should do before we close up?
No, I think that's it. Thanks everyone for joining.
Okay, thank you all, and we'll see you at the next webinar. Bye-bye.
Bye everyone.